How did we pick 12 indicators to focus on? Here is what we did. We distributed surveys to an OHT representative. We have an OHT evaluation contact, and we wrote to all of them and said, who is the best person to provide input on the data that we are sending out? And so that might have been the evaluation lead. In some cases, it was somebody else within the team. There were 56 OHTs invited, 42 responded, 75% response rate. Most of the respondents held positions as executive directors or leaders in analysis or population health. And the OHTs were asked a little bit around how we had provided the data before and if they wanted something similar or different. And then we asked them to rank the importance. So we forced, and everybody didn't like doing this. In fact, I think we had one team refuse to do this, is to rank the priority of the indicators in order for us to be able to focus in on those things that are most important to the Ontario Health teams themselves. So this is one of the questions we asked. Do you think it'd be better to have a report that provides a full set of indicators for one of the existing sets? Overwhelmingly, so 65% of the respondents said that we should provide a report that includes a limited number of indicators from each of the above. What are some of the results of the top priority indicators? These are shown ranked. We had a 10-point ranking from most important to least important. Most important is shown in the bright green on the far left. So we really looked at what proportion of people said this was the most or second most important. Looked a little bit at the third, but mostly we made the decision based on that. And so you see here, if we drew a line somewhere around 25%, of the indicators beating more than 25% being the top two priorities, you see ED visits best managed elsewhere, continuity of care, and ambulatory care sensitive hospitalizations. But I appreciate that these are areas that are somewhat looking upstream and towards a more integrated and population health approach. From the mental health, we again had high frequency and repeat visits being suggested. Within the older adults, only one really made it up into that top range, being repeat fall-related visits among those identified as frail. The other ones, not to say that this isn't an important area, but it wasn't a common area of importance across all OHTs. So everyone will have their own indicator result for all of the frail older adult indicators in that spider diagram. But in all of the different stratifications, we focused on those ones that were most common across all teams, and that's for our provincial work and then also for your own team's work. And then for the end of life, we had palliative visits in the last 90 days of life and ED visits in the last 30 days of life. Finally, from the CQIP indicator set, ALC days, PAP test, and up-to-date mammograms, and the rate of ED visits as a first point of contact was actually included from the mental health one. And here, so that is an indicator that is included in the reports. So here are the indicators, and you see where they came from now, the top chosen ones: ED visits best managed elsewhere, ACSC hospitalizations, physician continuity of care, 3 in the mental health area, 3 from the CQIP area that are not reported elsewhere, 1 from older adults, and 2 from palliative and end of life. So that's where you said we should land.